You're so tired. Hello, everyone. Can everyone hear me okay? Yeah, am I too loud? No. My kids would tell me I'm too loud. So you're all really, really welcome to our 6th Marie Keating Foundation BRCA seminar. We're delighted to be back, and we're delighted to be back here in the Clayton. I think this is the 3rd one in the Clayton. So we are in for a very, very busy day today. So I'm beginning the warning sign from Fiona there. I have about 5 minutes to go through a few little things with you. So I'm Bernie. I'm the Assistant Director of Nursing in the Marie Keating Foundation, and I'm Manager of BRCA Services. I think many of you probably know me, but for those who don't know me, that's who I am. So a few little things around the housekeeping. Phones, if you wouldn't mind putting them on silent, if that's okay, including my own. That on silent. And sure, obviously, if you need to take a phone call, if you wouldn't mind just popping out. Fire exit is the second door there on the left, and that takes us out to the car park. We won't need it, fingers crossed, okay? So, you know, teas and coffees are at the end of the room there, and there's also water. And then lunch will be upstairs, first door on the right, into the Bay and Sorrel restaurant, and we're in the Sorrel lounge. And the soup is not sorrel, it's tomato. So we'll be up there for lunch, 12:30 to 1:30. So, and let me just see a little bit then around the housekeeping. So to continue the housekeeping, I should say, probably getting into the video recording. There will be some recording, but we will not be, yeah, Jane here, see Jane here in the corner. Say hi everyone to Jane. Jane is our Senior Communication Officer. Jane, we're not hybrid in that people can come in online, but we are recording some of the presentations that we have permission to record, and they'll be available then as a really good resource for anybody afterwards or anybody that hasn't seen it already. And then the thank yous. First of all, thank you to you all. Thank you to everybody for coming today, Friday. You won't be sorry because we have a great agenda lined up today, and the agenda is based on your feedback. So post today, there will be a feedback form sent out to everybody. We'd really appreciate it if we would fill it in, because negative or positive, that's what helps us build on all our BRCA services, including our next seminar, okay? And now the glasses go on. You notice the glasses going up and down all day here. So big thank you to our sponsors, MSD and Astra Zeneca. Without them, we really couldn't be here. As a little charity, these things take a lot of funding, and we certainly couldn't have made it free without their help. They keep coming back, and we are so grateful. And please come back again next year. So a big thank you to our stands as well. At the end of the room there, you'll see Anne from Roaches setting up. Hi, Anne. We will have Christina Cahill coming in later as well. And Christina will pop up to the top, Dr. Christina Cahill. She's going to talk about a new psychological needs assessment that's been done. There you are, Christina, just spotted you. In Ireland. So Christina will come up and chat about that. She will also have a stand at the end of the room. Isn't that right, Christina? Yeah. Thank you to our expert speakers. Really fantastic group of expert speakers today. You all have the agenda on your chair. We'll go through it very, very quickly because I know I'm on the clock here. But you know, we have speakers coming in to us that come to us again and again. We'll be talking about a lot around communication and research and new developments. So yeah, it's going to be fantastic, a really fantastic resource. Big thank you to the Repeating team, and thank you to Liz, our CEO. I think Liz was getting in charge of me coming back. Can we have a bit more, Liz? Can we have a bit more? But thank you, Liz. And thank you to Helen here, our Director of Nursing. Jane over here, as I said, Jane O'Toole, our Senior Communication Officer. There's Fiona down there. Fiona Sullivan's our BRCA admin support. We've got Ginny outside the door. We've got Linda Keating here. Where's Linda? Our co-founder. There's Linda down at the very end there. And to all our nursing staff, to everybody. It takes, you know, a whole team to bring a program like this together. As Anne gets her bra out down there at the end, and her bra. So let me see, who have I forgotten here? Hopefully I haven't forgotten anyone. Talk to you about feedback. Of course I have forgotten somebody. As I said, I manage our BRCA services. Our wonderful BRCA peer support volunteers. Many are here today. We'll be bringing them up after lunch to introduce the ladies to you all. These are people who volunteer their time to be of support to others with the BRCA variant, and really from around the country, and have come up from around the country. And so we're really, really grateful. And then we will have two fantastic ladies come up here at the front and discuss personally communication with their family. We'll have Tara and Lisa come up later in the afternoon. So yeah, really big thank you to you all. So moving on swiftly here. So as I said, you have the whole agenda there. BRCA in the eye of the beholder. We all know beauty is in the eye of the beholder, but so is BRCA. There may be lots of commonalities, but there's lots of differences. You know, when somebody has a BRCA1 or BRCA2 alteration, their choices vary and differ. So, you know, and there's certainly a difference in what we'll be talking about today, communications and communication skills. So we go back and chat to our members of our BRCA community and ask, what do you want from this seminar? And there was a big request around communication and research. So that will be, you'll see the big focus for today. I'm told I have 1 minute, so I better get very fast. As I said, here again are pictures of all our really expert speakers today. I won't have time to go into each one, but as I introduce each one, I will give you their bios. But we're so grateful to you all, you know. This is what's moving Ireland along. I would have managed BRCA services in Canada for 15 years, and we're certainly catching up fast. And it's thanks to all these experts in the room. So, first up is Mr. Eoin Hanney. Eoin is a senior genetic counsellor, and Eoin has worked with us in the repeating over the last 5 years. Very involved in our BRCA peer support training, has spoken at our BRCA seminars before, and we're so delighted, Eoin, to have you back again. So Eoin is a senior genetic counsellor based at CHI Crumlin. Eoin has at least 10 years experience working as a genetic counsellor, and he has a specific specialist interest in cancer genetics. So without further ado, and I'm within time, I didn't get the red wand, we'll move you on to Eoin. Thank you so much, Eoin.
Can you hear me now okay?
Yeah.
So thanks very much for inviting me here again, guys. It's great to be back. So what I'm going to do today is just do a very brief overview of both genetic services and the referral process as well. Now, again, I'm probably speaking to the converted a little bit in that a lot of you may have already been through this process, but maybe for those who haven't yet been through it, and maybe just to lay out how things are working at the moment, but how they might work in the future as well. So an overview of today. I'm also going to sneak in a little bit about what is genetic counselling, because whenever I get a chance to speak, I just like to give my version of what it is we do and why it's important for particularly women and families with BRCA1 and BRCA2 variants. I'm going to talk about the current model of care in Ireland for BRCA testing. And then I'm going to review, I suppose, what the current genetic services in Ireland are, how to go about getting a referral and what's important in regards to that. And then a little bit about the future model of care, which Caitríona might follow up on a little bit from the NCCP later on. So, before I even start, if you've seen me talk before, our peer-to-peer support group are here, and some of the slides look familiar, so apologies for that. So, the first question is, what is genetic counselling? So, the definition of genetic counselling is that it's a communication process which aims to help individuals, couples, and families understand and adapt to medical, psychological, familial, and reproductive implications of genetic contribution to specific health conditions. You know, that's very, very wordy, but what I'm going to try and show in the next few slides is what is involved in genetic counselling and why it's important for individuals going through genetic testing. So there's a little bit about interpreting family history, there's a lot of it is kind of patient education, and then there's the counselling and support element, which I think are kind of hard to define, but are really, really important. Before I keep going, there was one bit I just wanted to kind of clarify, just from the language we sometimes use, in regards to kind of what we would clarify as being like a diagnostic test versus a predictive test when it comes to BRCA. So when we talk about diagnostic testing, what we're talking about is testing somebody to see, can we identify, is there a faulty gene causing a problem in this family? So it's testing a woman with breast or ovarian cancer, or maybe a man who's had breast or prostate cancer, to see, can we identify, is there a faulty BRCA1 or BRCA2 gene causing the problem in the family? That's what we kind of term as like a diagnostic test. Then on the other side of things, we have what's called predictive testing. So that's where when we know there is a fault in the BRCA1 or BRCA2 gene in the family, and we're offering testing to other people in the family, so siblings, parents, children, other wider relatives. And so there's slight differences in those two things. What I wanted to do was just kind of very quickly go through, I suppose, two typical cases that we might see as genetic counsellors. One being a kind of diagnostic testing case and one being a predictive testing case. So I'm going to use this case study that there's a patient who's diagnosed with breast cancer at 45. What will we talk about in clinic? So genetic counselling appointments are a little bit different in that generally we have between 30 to 45 to maybe sometimes 60 minutes to sit with the patient to talk through everything that's kind of entailed with genetic testing. So the next couple of slides will try to illustrate why it's important that we have that time and all of the different things that can come up when we're in the clinic with patients. So the first thing we have to do in this case is we take a family history, we look at the other kind of pattern of cancer in the family. Is there a strong pattern there? Does this person meet criteria for testing? Do we need to go ahead and do diagnostic testing? Then we'd have to talk about, well, what are the implications for this woman if we do find a fault in either BRCA1 or BRCA2, both for herself and for her family? Well, we talk about the fact that, well, it might provide an answer for what contributed to her breast cancer diagnosis in the first place. And it may inform things like her treatment. So it might give her surgical options, it might change her chemotherapy options. So there's treatment benefits. On the other side of it, there's also then the burden of knowing that there might be an increased risk of developing a new breast cancer and or developing ovarian cancer in the future. The individual may need more surgery. And then there's, I suppose, the really important bit for me is kind of the timing of the test and the timing of the results, particularly kind of depending on where this woman is on her journey. If it is that she's kind of right in the middle of just been diagnosed, that can be a very hard time to take that information on board. Or it could be that we're 5-10 years down the road and actually they've left the kind of cancer story behind, but then this brings it all back up again. So that can be a quite delicate bit, is that where is somebody with all of that? The next thing that's really important then is the implications for the relatives as well. And then the psychological and emotional impact of finding something if we do the test. So, you know, sometimes 45 minutes isn't actually enough to kind of get through all of this information. Then I just wanted to quickly kind of show you, well, what's kind of slightly different in a predictive testing appointment. So again, if you imagine that we did find a fault in the BRCA1 gene in a previous woman, and now her 25-year-old daughter is coming forward to have genetic testing for the fault that was found in her. So we'd be talking about what is the risk of having the faulty gene and the risks associated with that, and what is that individual's understanding or interpretation of the risk. And that can be very different depending on what your family history is like, because sometimes people are being tested, but actually it's a very distant relative that they don't know, you know, where it's linked through maybe men in the family and they haven't actually had an experience of breast or ovarian cancer in somebody quite close to them. Or it could be that it's a mum or a sister or an aunt who's been diagnosed, actually their experience is very kind of close at hand. So it's about making sure that they have a good understanding and interpretation of their risks, talking through, well, what are the options if we do find you have the gene in regards to screening, detection and prevention, talking about the psychological impact of the test result and or I suppose the risk reducing surgeries that entail with that, and trying to make sure that people are in the right frame of mind and have support with that side of things. Again, that issue of timing comes up as well, particularly for maybe a 25-year-old woman who it might not change things straight away because her risk of developing cancer might not be until she's older. She might not be accessing screening or services until she's maybe 30. So the timing of the test is really important, particularly for younger women. Are they in the right frame of mind? Is there other stuff going on in their life at the moment? So that's something we'd explore as well. We talk about inheritance, so the risk for this person's children or future children if they haven't started a family yet. We talk about things like the reproductive options, such as pre-implantation genetic diagnosis and the different options that are available there. If there's siblings being tested together, which is quite common, or maybe being tested at similar enough times, we talk about the possibility that they might get different results and how people might feel about that. And again, quite commonly, there's this thing called survivor guilt, where actually people who get a good news result end up feeling worse about things psychologically in the short term. And so just exploring that with patients and encouraging them to have those conversations. The testing can provide reduced cancer worry. You know, if we find the gene and someone is getting the screening or the surgical options that they need, there's this idea that knowledge is power. And I think there's a lot of people who choose not to go ahead with testing, but they're not the group of women we tend to see because they don't seek a referral into our service. So many of the women who have referred into our service for this kind of test have kind of half made the decision that this is something that they want to know. And then we'd also explore the motivations and support and coping mechanisms on the individual to see if there's anything else that we can do to help them with that. So that wasn't really what I was asked to talk about, but I wanted to just get that in there. In regards to referral pathways, the kind of traditional pathway for a referral for genetic testing in the diagnostic setting would be if an individual was diagnosed with breast cancer or ovarian cancer or prostate cancer, and they mentioned that they had a very strong family history or there was something about their cancer that was unusual, they would be referred by either their GP, their oncologist, or their surgeon into the genetic service to see does this person meet criteria for genetic testing. What we generally do then is we'd send what's called a family history questionnaire. So many of you might have had to fill one of these in over the years, where it's you fill as much family history as you can. If you get one of those forms, it's really important to put as much information about the people who have had cancer in your family on the forms. And the forms aren't one size fits all, and that like there isn't bits for cousins or more distant relatives sometimes. So put more information if you have it, because it helps us then to kind of accurately assess your risk and decide do you meet criteria for testing or not. If the person meets criteria for testing, you put a waiting list for an appointment, and then you'll be seen and we'll talk through the testing process like we kind of mentioned there. Really importantly, we can accept urgent referrals if they will alter treatments. So more commonly now what we're getting is that maybe if a woman's diagnosed with triple negative breast cancer at a young age, she might be referred into us for testing very kind of soon after her diagnosis so that we can get her result back before she needs to have her treatment. And therefore that will help the surgeons and that patient decide whether they want to have a single mastectomy or a double mastectomy, depending on the results of the tests. In regards to predictive testing then, so when we know that there is a pathogenic variant in a family and you want to be referred for testing, you do need a referral from a GP or a doctor. So it can be any doctor, but it's not both services, both in Crumlin and in St. James's, don't accept self-referrals at the moment. Now, it is something we're reviewing because we do want to open access as much as we can. You know, getting a GP appointment can be tricky, and you might have to pay for the appointment to get the referral and things like that. So we want to make it easier, but at the same time, we need a doctor that we can write back to if the patient doesn't show up or if there's been an issue. When you're getting that referral, what's really important is to, if possible, if you know the family reference number. So most genetic services, whether it's in Ireland or the UK or anywhere, we kind of treat, we have family files. So there'll be a family reference number, and that will help us then find out how you fit into the family. If possible, to send a copy of the test report from, if it's sister, mum, cousin, if you have a copy of that report, to send that in with the referral, so then we know exactly what we're looking for. Or if we don't have a copy of the report, the name and date of birth of the person who's been tested, and we can find out who they are and how you link into that family. Very commonly what we do as well is if we have tested somebody and we found that they have a fault in BRCA1 or BRCA2, we might give them what's called a to whom it may concern letter. So it's kind of a very standardized letter that says, you've been given this because a fault in BRCA1 is found in your family reference number is 1, 2, 3, 4, 5. Ask your GP to refer you to Crumlin and that kind of thing. So even that letter will help us then fit you in. How things are kind of changing at the moment and will definitely change in the future is this idea of mainstreaming. So what we mean by the term mainstream is that this will be diagnostic testing for people who have cancer at the point of diagnosis. So it'll be testing women with breast and ovarian cancer at the point of diagnosis, or maybe men with prostate cancer at the point of diagnosis, to see if they have a fault in BRCA1 or BRCA2. I suppose the oncologists and the surgeons are really keen on this because it means that it might change treatment options for their patients. So that's why they want the diagnostic testing happening sooner. So it can, as I was saying, it can alter the treatment options for different groups. So currently, one of the things, so if someone has breast cancer, it may direct what type of surgery she has. So if we do a test and there's no BRCA1 or BRCA2 pathogenic variant, then they'd have more conservative treatment. So wide local excision or whatever was needed in the first instance. Whereas if we did testing and there was a fault of BRCA1 or BRCA2, that woman might be given the option to have a double mastectomy as her frontline treatment, which will treat the current cancer, but reduce the risk of something new happening in the future. Other reasons for mainstream that have come along in the last little while as well have been, so women who have metastatic ovarian cancer or men who have metastatic prostate cancer, if they have a fault in BRCA1 or BRCA2, they can get access to special types of chemotherapy called PARP inhibitors. So again, a lot of the surgeons and oncologists are keen for their patients to be tested for that to see what do they access those drugs and will that give them better outcomes and better treatment. Part of the future will be of genetics across the board is that more and more individual specialties will be doing their own diagnostic mainstreaming testing, and then it will be probably the genetic services who will pick up the pieces when families are found with something new and then testing other people. But again, that's all kind of going to change as we go forward. The benefits of this is that it can alter treatment, it can help patients make more informed decisions. It reduces the wait time to be seen by clinical genetics because you're getting your testing done at the start of your journey, and families can be informed of their risks sooner. On the flip side, this is the thing I keep coming back to, would be the idea of the timing and psychological impact of both patients and relatives of having that testing done at that stage, because sometimes we're referring in women and they've only been given their breast cancer diagnosis 2 weeks previously, and they're just starting to get their head around that and all this idea of treatment. And then you're throwing on, oh, if you have this, your breast cancer risk, your ovarian cancer risk, changing your surgery. And then the other layer is then, and then actually we need to worry about your sisters, we need to worry about your daughters. So that's the bit that I worry about when it comes to mainstream, is that the psychological impact is kind of more intensified because of it's all happening at the same time. So again, this ongoing training with oncologists, surgeons, AMPs, etc. The NCCP are working on this, and this will be a bigger part of how genetics works in the next few years, I imagine. Just a quick overview of current cancer services. So in Crumlin, we have about 7.5 full-time GCs and 5 consultants. In James's, there's about 5 genetic cancers and 2 medical oncologist geneticists. And then in the private service, Dr. Gallagher runs clinics in the Mater and Hermitage, and he has, I think, 2 genetic cancers and 2 nurses working with him at the moment. Just to point out, you don't have to be referred to the same place that your family has been seen previously. It is helpful because there's less chasing up on our end, but it doesn't matter. And I've yet to kind of make sense of it. Some GPs only refer to us, some GPs only refer to St. James's. So depending on where you live and who your GP is, they send you to wherever they send you to. I don't fully understand it. So this year, this document called the National Strategy for Accelerating Genetic and Genomic Medicine in Ireland, that was published just before Christmas. But basically, HSE Department of Health are coming in and they want to fix genetics and genomics in Ireland and get it going for the future. They're going to establish this thing called the National Office for Genetics and Genomics. The idea is to expand genetics and genomics service delivery, address the long-standing issues with funding and staffing within the service, focus on developing the workforce, enhancing the clinical service, and a big focus on that mainstreaming piece to get people tested faster so that we're identifying families sooner. And again, there's this kind of draft document with the hereditary cancer care model. And the idea will be that there's going to be like a specialist cancer genetic service that will be kind of like the hub, but that kind of regional cancer centres will be doing much more diagnostic and even maybe predictive testing out of the realms of genetics with kind of support from genetics, if that makes sense. They're developing national referral pathways and protocols that everybody's kind of getting the same, which again has been an issue. The mainstream diagnostic testing, there'll be a genetic cancer maybe linked in with each regional service, and there's going to be AMPs and CNS is going to be really important to all of this. And the idea is that you're going to get more local access to service, shorter waiting times, and that is kind of a standardized care across the board. That's the plan, but I'm not sure how long it's going to take for that plan to come into place. But the fact that there's kind of momentum behind it is good in my eyes. So that's all I have to say.
Thank you so much. Marjorie, can I just say, if you have any questions, hold on to them. We're going to have a Q&A around 12:10, just after Christina. So yeah, thank you, everyone. I think that leads very nicely in here to Dr. Trina McCarthy. Dr. Trina McCarthy is a consultant in public health medicine with the NCCP, National Cancer Control Programme. Trina is a medical graduate of UCC and a fellow of the faculties of public health medicine in Ireland and the UK and of the Royal College of Physicians. She has worked with the HSE NCCP since 2008, focusing on areas such as GP referral pathways, inherited cancer predisposition, and addressing modifiable risk for cancer. So Trina has been with us many times to present, and I think it leads nicely into what Eoin said, because Trina is going to talk about the development of BRCA services in Ireland. So over to you, Trina.
Good morning, everyone. You can hear me okay?
Yes.
Thanks for inviting me back again. No, excellent. Thanks for inviting me back again this year. It's lovely to meet you all in person, which is nice. And I was mentioning this at the end again, but with particular thanks to McVeigh, Hanney, and the BRCA Peer Support Group for their invaluable work in this area. Owen has stolen my thunder. He apologised in advance for stealing my thunder about some of the development of services, but I think he's given you a very good overview there at the end. Thanks, Brian. And I just want to, I suppose, walk you through a little bit more of the detail and how we see things developing. And I did promise before as well, I don't want to be too negative, because I just feel the pace of this is a little bit slow, but I'm just trying to balance it between it's slow, but we have a plan, be a little bit optimistic and cautious at the same time. So I work for the HSE National Cancer Control Programme. So we have a national cancer strategy that we're working to implement, and just to highlight, molecular cancer diagnostics is kind of, the role of genetics in cancer care. While they were mentioned in the strategy, they were there and known already, as being important sort of new focus, we say, for this strategy. It's just taken us quite a while, I think, to get things moving and get to the plan in place. But we have that very much in our strategy already as a priority. And then thanks to everyone who last year at this as well, we spoke about the health needs assessment, where we looked at, people shared their experiences, particularly with the BRCA diagnosis and what that means and what the challenges are with the services. So I suppose I want to take it through where that has informed the plans, but I suppose it's also, for across people with other cancer predispositions, it was very valuable and important in terms of what we'll be doing next around BRCA services, but also it's, the experiences of people with BRCA are very reflective of people with other cancer predispositions. They're unique to your condition, but also, there are lots of parallels. So Eoin has already mentioned the national strategy for accelerating genetic and genomic medicine, which is across genetics and genomics in its kind of broadest sense. And there was a recognition that, Ireland had a really kind of step up that needed to be made in terms, across the board in terms of laboratory services, data, workforce, and he's outlined a lot of these issues. So we have that piece of work which has happened, and then also I suppose from a working in the cancer sphere and what it means for people with an inherited cancer predisposition, that hereditary cancer model care. Again, we've had great engagement around developing that. But I kind of want to take it through a little bit more slowly, maybe the recommendations of that as well. And that's going to be really our blueprint for saying, right, okay, this is what we need to happen. These are the resources we need. These are the pieces we need to work on. So I'll try and cover that as quickly as possible today. So the kind of HSE Department of Health strategy covers, there's quite common areas across that. So the workforce plan, we have an awful habit of just, asking the UK to train our genetic counsellors and then asking them nicely to come home. And, that we need sort of a sustainable way of getting people trained up in Ireland. There's that office that Eoin mentioned already and the whole kind of data infrastructure. So a lot of those things, I suppose we'll be looking for the National Genetics and Genomics Office to drive those forward, but we'll be, again, sort of from the cancer side, making sure that, that it meets the needs we've identified. And even within, if you get a chance to look at this document, you'll see within it, one of the patient representatives, Margaret, gave very generously over time and shared her BRCA story, and Karen, who many people know as a cancer geneticist, spoke about her experience and working in the area of ovarian cancer and BRCA testing and how things are changing with mainstreaming. So it's a general document, but it very much kind of covers both the patient and the healthcare professional experience in this. So to cover kind of more specifically today, from a hereditary cancer point of view, this is sort of an NCCP led with a very, very broad group, as I said, with lots of engagement. But we really look at the services for both identifying cancer predisposition and managing people with it, and what structures would we need to put in place for that to happen. I don't need to tell this audience what the benefits of that are, across the board, from reducing your risk, identifying cancer early, how it influences your treatment, what reproductive options may be available, and then the benefit to your relatives. It's not just, the first person identified with this. The whole point is, to identify predisposition and manage the risk across your whole, family cascade. But the vision of the document, I suppose, what are the things that we really call out? One was about, putting some kind of structures and governance around this. And I'll come back to it later, but it was actually one of our Lynch syndrome patients would often say, like, who's responsible? That's actually often the problem with these services, if it's, one particular discipline you're talking about, or a condition that's just looked after by gastroenterologists who say, well, we just need more endoscopies and the service will look after that. The whole crux of cancer predisposition or genetic predisposition is often that, it influences so many different aspects of your life or aspects of services that, it needs multidisciplinary working, and that's fine, but who's actually going to take ownership and make sure it works? So that's been one thing that's been really called out. The equity of access, so wherever you are in the country, that the services would be put in place that you need. The idea of having national guidance, again, that Eoin mentioned earlier. The standard care principles that people may be familiar with in terms of getting the right care by the right person and at the right time, but also had come through quite strongly. That doesn't necessarily mean patients are saying everything needs to be on my doorstep. I want the appropriate services that can be delivered safely as close to me as possible. But if I need a procedure and I need to go to a centre in the country, once off for that or whatever, I want that. I want the best care. I don't want to be in a situation where I can't get it because I'm west of the Shannon or whatever. So yeah, that's a something that came through very strongly. And using technology, virtual assessments or supports virtually, and making the most of those things appropriately. Timeliness, again, not just diagnosing things, but having your risk reduction options all kind of put in place in a timely way. Having comprehensive and coordinated care, quality assurance, your supports, the broader supports as well that are needed in education and training. So just to look to kind of the structure of the service that's proposed within the document, it's very much around having your generalists, so that would include your GPs or your kind of non-genetic specialist people in the service, and having that kind of layer of the service and having those people up skills. So again, you heard stories of people saying, I've gone to my GP because I was told to go to my GP to be referred, and I was told, oh no, because that's your father, that doesn't count. Or, to make sure that those things don't happen. You don't have to be a genetic specialist to be trained up to that level, and then to support them with protocols. So it's very, very clear, if you have somebody, this is where you send them. The regional cancer predisposition services, that's around having a comprehensive service covering all of the aspects that are required within your region around both identification and the ongoing management. And then the specialist cancer genetics people, and that kind of very specific resource, but using them most appropriately and using that expertise and making sure they can be accessed when required. So the generalists I've mentioned, I won't go through that, but again, it's just the education initiative, I think, are probably one of the big things in supporting them with the pathways. And let's jump down a little bit. So whereas in the regional level, the kind of tier 2, that's really where you want to have maybe this mainstream diagnostic testing that I was mentioned. How is that delivered safely within your area, and what are the pathways there? What are all the aspects across delivering the healthcare to the people who have something identified then, so that you have within that whole regional cancer predisposition service, which is dropped off the top. Somebody is looking at my region, whether it's the Cork and Kerry region, do we have these services? If we don't have the services, where are patients going to go? If they need to go to Dublin, let's have an arrangement to say, you're going to go to James for this, or you're going to go to Pullman, or you're going to go to plastic surgery for something, and to make sure that every region can look at the full pathway and cover all those things off. So the workforce there, and the one I've slightly wobbly circled is, I suppose, the clinical lead. This was the who has overall responsibility for cross-flow services. That's where we've been tripping up a lot of times. So, and it's also from the genetic service when they're referring people back to a hospital, knowing where you're sending someone back to, who's going to take care of this person in the broadest sense. So you can have, and this isn't just for the BRCA population, as I said, this would be for somebody saying across all inherited cancer predisposition within your region, who's taking the responsibility. But then within the individual services, that there would also be a workforce built up there that have an interest and a responsibility for following up things. And also, those very, very important supportive services, such as psycho-oncology services, reproductive options, how are those knitted in your region again? And that needs to be put out as well. I'll come back to the genetic counsellor, who's just flagged here as well, but this is really part of the specialist genetics service, and how does that reach into the regional service, and how could that be networked? That's something we need to get right, whether it's a physical, genetic counsellor assigned and employed in your area, or whether you have somebody that's networked in and does virtual clinics. But there was a very strong feeling it should, in most cases, it's something that should be delivered in your region. So the clinical lead very much said, as I've mentioned, about developing the service locally and adhering to protocols and taking responsibility. Specialist cancer genetic services, I think we have some really, really excellent people in the country, and it's about, we need to expand that service, but also make sure that they're networked in, make sure that, we can really have people worked up beforehand, have testing done in other situations where appropriate by the people within the regional services. So again, they're supported by protocols, but they also need to be able to call on specialist genetics. It needs to be whether it's a patient has a difficult, a more complex question, or whether somebody's actually, this person really needs to talk to a genetic counsellor as opposed to a breast surgeon or breast AMP on this. So it's having those things networked in, and I suppose that's the piece we said about having a piece of specialist genetics embedded in your regional cancer service is really where we want to get to. It might take a little while to get that up, fully implemented, but just whether it's virtual or in person, and it's something which sort of reflected across genetic services and the role of specialist genetics, I suppose we've called out around that, that expertise area, which I won't go through there in the interest of time. So just for implementing this is always, and this is what happened with the BRCA needs assessment. I think, the big question when we finished that piece of work was, well, how are we going to make this happen? There wasn't an implementation framework against this, and those things needed to be answered maybe against genetics and cancer predisposition overall. Just to outline, I suppose, what are the next steps that we've outlined, and I suppose briefly just to mention some of the staffing and resources that have gone to date. So with the cancer strategy funding, we've been trying to pick away and put some extra resources. We got no money this year, but other years, making sure that we put in extra genetic counsellors or consultants and admin support around this area, because it can be quite complex with the navigation, some excellent CNSs and AMPs, and we'll be hearing from Carl later on. But especially those working in the breast services, maybe kind of a younger service from the gynae AMP side of things, and then I will mention about the online training for those people doing mainstream testing. So for your people who aren't geneticists but are in breast teams or gynae teams, but they would have some accredited training, so they would, they're not sort of discussing these tests blind. They understand the implications of how to address them with the patient and identify when somebody actually needs to talk to a counsellor before the test. So that's something which is under development and should be launched this year as well. So I had a couple of minutes, 2 or 3, just to wait. 6 minutes, great, so not too bad. So I'm just going to cover the areas and implementation and highlight 1 or 2 areas, and then I'm happy to take questions later on. So the first area here is really about just putting the structures in place. So it's probably a little bit small up there, but I'll just jump into 1 or 2 areas. So for example, this National Genetics and Genomics Office is kind of in shadow form already. So we're already linking with them in terms of, they've got some money from this year and saying, well, we think there are gaps in certain places, or around the workforce issues, that we just make sure that, what's happening there is going to be to the benefit of people with cancer predisposition as well. And the clinical leads within the regions, I think that's another thing we really want to push forward. So we have people to link with and work with and can ask for money together, I suppose it's kind of a thing, and have people to be pushing it within their regions for us. The development of the network services or the multidisciplinary teams nationally, that's the next area that we need, that we've covered in the model care, and that's about, in particular, how that genetic counselling network arrangements. So there've been examples of outreach, in genetic cancer before, but how to make sure that's across the whole country, there's access everywhere, and everything from patient information moving safely, or whether how those clinics will be supported locally. So that needs to be developed, and then having those standardized pathways to back that up. And the education training, obviously, across the whole, development of the workforce. So particularly looking at those I mentioned earlier, that the generalist staff, the people who don't really, maybe see themselves as working in the service, but there are those that will either be maybe going to first off as a GP, or maybe within another service that doesn't treat people with cancer, but maybe it's a gastroenterologist or somebody else who needs to have that level of understanding of this kind of new service and new area, when you think there's people who did their degrees or their training a very long time ago. So to bring everyone up to the same level and know what's happening and understand the pathways as they're developed as well, because there's no point having those and not having them available and understood by people. And in the career pathways I mentioned earlier, that we're actually growing the workforce in Ireland for this need. Clinical guidelines and pathways. I mean, there's some excellent, we look at things that you say from the Royal Marsden quite a lot, and Terri McVeigh is giving a talk later. So there's some excellent guidance internationally that a lot of people follow, but I suppose just to have things from a clinical guidance point of view clear as to what we're following, but also like pathways are a little bit more than that. So sometimes people know what needs to be done, but actually, where is my patient going to get this done? I think that, the clearer that can be, and the agreements, and patients shouldn't be getting lost while their team are trying to find somebody to carry out a procedure or whatever. So that needs to be much more comprehensive. So that's one of the big things, and to involve, so we'll be having, a BRCA specific patient pathway for Ireland, and having that agreed, and then within your region saying, how are we meeting each of those steps within the pathway? Literally knowing where this is going to happen, if it's in your region or outside, kind of, it doesn't matter, but just need to be clear about it, have it agreed, and have it results. And then the knock-on from that is actually, that needs people, it needs resources, it needs theatre space, it needs all these things. But at least if you've mapped out, what you need, then we can go with the ask and seek funding, which you can do, but when you have sort of a strategy and model care. patient information and support, absolutely. I mean, with the partners in medicating and the peer support, but just again, how, you know, when somebody comes into, you know, even how do they find out about peer support? You know, even at the very start of your journey, how are you networked in there, or what other information are you given when you're discussing getting tested in the first place, for example? So we have lots of sort of maybe consolidation of certain information resources, but also I suppose in a broader sense, you know, how best to access that, you know, how do people find these things, you know, is everything put on a website and everyone goes there, or, you know, so we've had a lot of discussion of that with the Lynch group as well, in terms of, you know, people have different ways of accessing information, but you just need to make sure it's correct and it's appropriate and it's maintained as well. So kind of looking at that in the broader sense. And the data requirements and IT infrastructure, a fair bit of this maybe falls into, you know, having to line it up with the rest of genetics and the National Genetics and Genomics Office. But particularly we want to be involved in discussing with them and involving patients in the discussions around patient registries. And again, it's something in the UK they've been looking at, you know, whether it's useful to have a registry, whether people are comfortable with that, or whether it's something that is just data managed locally by your own region and that. So there's a lot of options there, but we need to work out what's the best for our service and our population here. And then how do we monitor the service? How do we make sure it's doing what it's meant to do? So I think I've just about come to the end of time, which is good. And we'll have questions and answers later, I know, but I just really want to thank everyone who was involved in the advisory group on hereditary cancer, in particular, Nick and Rachel, the patient representatives, a broad range of healthcare professionals, those who responded to the consultation itself, and then all the patient advocates, because I can't do my job without people sort of publicly saying how important this is and getting the sort of ministerial buy-in and the political buy-in. So it's really, really important, you know, to keep that work up. And I think we're sort of at a space now where there's some momentum around this, and we just need to do the extra push to make sure that this gets the priority it deserves to get implemented. So thanks very much.
That's very good. It's nice to have a roadmap and a plan. And I know often it might seem like things are not moving or not moving fast enough, but we certainly know, Marie, teaching from when we started our BRCA services 5 years ago, we've come a long way. And we've definitely got powerful voices that together with the HSC will move it further. So thank you so much to both Trina and to Eoin. And next we have an essay from Dr. Terri McVeigh. This is an entire presentation here. So we're going to have a pre-recording in a moment because Dr. Terri McVeigh right now is presenting in the US. So she couldn't be here in person. I know that Trina alluded to Terri and the great work that Terri does in the Royal Marsden. So don't tell Terri, because I'm not going to read it out word for word. But Dr. Terri McVeigh has presented further repeating in the past in our BRCA seminars. She's always invited back. She's so easy to listen to. She's so knowledgeable. She's got lots of background as well as being a medical doctor. She's got lots of expertise in clinical genetics. She currently works as a consultant in clinical genetics in the Royal Marsden, where I've done training myself. And she's also worked in Australia. She's very involved in education. And I know she set up the postgrad course in genetics in the Royal College of Surgeons. And I know a few people have taken it that says it's very, very, very good. She's currently also lecturing in Imperial College where my daughter is, and I have to get her to pop into her because I know she's very good. And she's also got, I don't think this woman sleeps because she does an awful lot of work around IT and healthcare as well. So as well as being an active consultant in genetics, she's actively involved in so many other areas. So without further ado, and fingers crossed this work, and Jonathan, I might need you for this, we're going to play a little video. So, yeah. I think I have to come out and slideshow for this. Yeah, Terri is fantastic. We did ask her for a 30-minute recording, but she couldn't get it all into 30 minutes. So apologies, and I couldn't clip it. So I didn't want to clip it because it's good information. And the recording, she said, we can share it. So if anybody wants the recording, let us know. info@themeeting.ie. So, moving swiftly along, and so sorry for holding up my next speakers. And we have got 3 wonderful ladies here today, who are all from St. James's, who are going to talk to you about the patient decision tool for women with a BRCA1 or BRCA2 alteration. Here I've got Carl in front of me, and Carl, if you don't mind, I won't go into everybody's bio, but we have, and I know that Trina mentioned earlier, AMPs, advanced nurse practitioners. We've got at least 4 here in the room, and in Forrestal, we've got Yvonne, and we've got Carl. And Carl, I think we'll just move into it. Is that okay? Because I'm conscious that you're probably all at this stage getting low sugars, and we don't want any hypos in the room. So, so Carl, over and out to you.
So, I'm Carol. I'm one of the advanced nurse practitioners from the Breast Clinic at St. James's, and I'd like to just thank you for the opportunity just to present on our web-based decision aid tool for women who have a BRCA gene. And it kind of follows on a little bit from what Trina was saying in terms of where to get the information from. Once you have a diagnosis, where can you get it? So I'm just going to talk very briefly about shared decision making and how it's in the context of a BRCA alteration. What are decision aids and why are they useful? And then just talk a small bit about what we've developed and where we're at. So within the healthcare model, there are 2 main types of decision making. There's paternalistic and there's shared decision making. Paternalistic kind of occurs when your healthcare professional makes your decisions for you, but it's in your best interest and really there's only one valid choice. So that would be applicable in situations where you are diagnosed with a meningitis, you need antibiotics, or a blood clot, you need anticoagulants. When you have, for example, in the context of BRCA, a very complex diagnosis, shared decision making becomes much more appropriate. It's as healthcare professionals, it's our job to give you the information and the recommendations, and then it's your job to consider that information and those recommendations and look at your values and your preferences so that we can reach a decision together. Essentially, it's the core of patient-centered care. So we're using evidence-based medicine. You're looking at your preferences, your personal values, and where you are in your life to drive the decisions that you make. And if we look at the literature, I suppose essentially shared decision making improves patient satisfaction, but ultimately it really improves patient care outcomes. So when is it most useful? Very, very simply, when there's more than one valid option available to you. And within the BRCA setting, you have many choices that you need to make. Do you have surveillance? Do you opt for risk reducing? Do you consider chemo prevention? And how do you make those decisions if you don't have that information? Decision aids are very different than being handed an information booklet. That's great, but what a decision aid allows you to do is to work through every single option that's available to you to see how you feel about it and what you want to do about it. So it provides you with a range of options available. So obviously in the BRCA setting, that's surveillance, risk reducing, chemo prevention, which hasn't really been spoken about much. And then understanding the probable consequences of those options. So what I mean by that is the benefits and harms associated with each of those individual options. And then you, as the person it is affecting, consider the value that you place on the consequences, and only then can you make that decision. Decision aids actively encourage women to participate with their clinicians in making decisions. So we're not telling you what you need to do, you're telling us what's best for you. So the evidence would suggest that in terms of decision aids, how do they improve patient care? And there was a very large Cochrane review in 105 studies that looked at patients who used decision aids. And what they found was that if you used a decision aid, you had a higher level of knowledge. A higher proportion of the people who used the decision aid actually could accurately had an accurate perception of what their risk was in relation to their specific illness. A higher proportion of people actually made a decision based on their values in relation to their treatment. There's less decisional conflict. So should I do this? Should I not do this? Because you had the information you needed in terms of where you were in your life to make that decision. And finally, it really improves the communication processes between the healthcare professional and the person it's actually affected. So with this in mind, my very lovely colleague over there, Yvonne, came up with this idea to develop a web-based tool because, as some of you would know, I know I see some familiar faces in the audience, the family risk service at St. James's is very well established, but we found even within our own service, depending on who you saw, there may be a conflict of information, but also the information was very, very dispersed. And so Yvonne worked hard because these sort of projects cost an awful lot of money to secure funding so that we could develop this decision aid. It is a collaborative project between St. James's Hospital Breast Care Department and the School of Nursing and Trinity. Lovely photos there for you. And you know, I suppose what was the purpose of this decision aid? So these are the risk management strategies available to women who have a BRCA alteration. So how do you choose which one you want to stick with? So we all know that surveillance is not a prevention, it's early detection. And that's with MRI and mammogram. And as you've already heard, it depends on your age as to which one you have or whether it's both. It's important to know that it's detection, not prevention. And that's obviously, we diagnose breast cancers at a much earlier stage, so the survival benefits that's very similar to women who haven't had cancer diagnosis. However, these surveillance has some harms, so it's very uncomfortable. I'm sure many of you in this room have had a mammogram. There are some false positives, so you can have a recall for something that actually turns out to be absolutely fine, but that's a very scary experience. And sometimes we are over-treating. If we move on in terms of prevention, risk-reducing surgery, we know at the moment, unfortunately, the literature suggests that the only ovarian option you have is surgery. And that reduces your risk of developing ovarian cancer very, very significantly. However, as we've just heard, that has its own harms in terms of overnight menopause, osteoporosis, cognitive health, cardiac health, all of these things. And in terms of risk reducing breast surgery, reduces your risk by 90 to 95%. That's excellent, but then you have the consequences of how does that surgery affect you psychologically, physically, and where you are in terms of your life. And the one thing that hasn't been spoken about is chemo prevention. And this is something that's used quite commonly within the US setting, but not so much in Europe, and you haven't heard anything about it today. And what chemo prevention means is taking a medication to reduce your risk of breast cancer by 30 to 50% while also having surveillance. And the drugs that we use are tamoxifen in the premenopausal setting and aromatase inhibitors in the postmenopausal setting. And that's a very significant risk, but what are the harms? And as you heard from Terri, some of the unusual harms from using this medication are uterine cancer, because it causes an increase in the lining of the uterus, and clotting, DVT in the leg. The other harms are menopausal side effects. So how do you make this decision? As women with a BRCA alteration, the decisions relating to risk-reducing strategies are very complex and very personal and subjective. Nobody can tell you what to do for you. And what's right for one woman is not right for the next. So we found, having worked in the family risk setting for quite a long time, that women struggle with the decision-making process and they're very overwhelmed by online information, particularly because it's so dispersed. And is that information actually accurate and is it useful? So therefore, we decided that when Yvonne and then we joined her, decided that we would try and develop a web-based decision aid tool to support women in making decisions about their risk management options. And ultimately, what we wanted to do was improve the decision-making processes for women, Irish women who carried BRCA alteration. It is important to note that this decision aid is specific for women who have been unaffected by cancer, because for those who are affected by cancer, the decisions they have to make will be slightly different. So just get into the technical aspect of it. It's a mixed method research project, and there's two phases to it. The content specification phase, which simply means what do we put into the decision aid and how do we present it in a way that you like it. And the second was the design phase. So in order to find out what to put into it, there was two phases, and this was the evidence synthesis where we looked at all of the literature in terms of what the management options were and what the benefits and harms of those options were. And then we also looked at the international decision aids that were available. Then we went to the experts, and the experts were you guys, were the healthcare professionals, were the advocacy groups like Marie Keating and Irish Cancer, and then the National Cancer Control Programme. And ultimately, we did focus groups with all of the different experts to find out what they felt would be best to put into the decision aid. The last phase was designing the design phase, so develop a prototype and to test. So I'll get onto that in a few minutes. What was crucial to the success of this project was involving women who had a BRCA alteration at every step of the way, because ultimately this BRCA decision aid isn't for us, it's for you guys. And so it was important to have a member as part of the advisor group in the government setting up the whole project. The stakeholders needs assessment, so the focus groups. I'll talk about the Delphi in a minute, and that was the consensus survey. So, you know, we know what we need to put into it, but let's finalize what exactly needs to go in and how we present it. And then where we are now. We've just nearly finished the prototype is the testing. So I'd like to thank anybody who's in the audience. I see a few who've helped us so far. We will be calling you for the testing. Before I move on, just to show you an idea, like sample of what the website will look like, I just wanted to share with you some of the findings from the focus groups from the women's focus group, and which I'm sure will resonate with a lot of you today. So the first one, which is no surprise, I'm sure, is receiving of information. So the women who attended the focus groups really expressed a need to get information relating to their management options and how they manage their cancer risk. And what came up most predominantly was the risk reducing options and how those options would impact on your psychological and physical well-being and your general health, but also on your family life. And a lot of women said that they needed to advocate for themselves to get this information, which is in this day and age is quite disappointing. So I suppose essentially after the information, how do you get access to it? So some people said it was just written letters on a page. It wasn't anything digestible. It was scattered or dispersed. A couple of the women on the group felt that their healthcare professionals were withholding information from them. You know, one person mentioned that they wanted to discuss some things at their appointment, but unfortunately they were told not to worry about it because they were too young. And then the evidence is conflicting, you know, and we found that ourselves in some cases that, you know, depending on who you saw at the clinic, you might get different information, or even online, when you compare the information, it could be very conflicting. In terms of cancer risk options and decision-making factors, there are multiple teams within this aspect of the group. And the one highlighted one was family history, and probably I would say more family experience. So we found that if there was a young woman who was diagnosed within your family setting, particularly if she passed away, that had a massive impact on how quickly decisions were made in terms of risk reduction. You know, there was a cousin in the family who was very ill and she died, and she was younger than me, so that's quite scary. In terms of fear motivated women. So when you get your BRCA diagnosis, you get these big blanket numbers of your lifetime risk. And sometimes we don't focus on what your risk is currently according to your age. And because of that, sometimes women seek urgency to surgery, which is the bottom one there. So for this patient, it was just the fear. I was terrified, and that was the reason I did what I did. It's mentioned a couple of times today in terms of fertility. And then I'm not specifically talking about the surgery, but as we know, there's no good screening option in terms of the ovaries. So we're recommending removing the ovaries at 35 or thereabouts for BRCA1 and from 40 onwards for BRCA2. So for some women who wanted to start their family a little bit later in life, they were forced to make the decision to have children earlier. Or for women who had children or were hoping to have more children, that decision was taken away from them because they were encouraged to have surgery. Particularly women with an earlier diagnosis, I'm 25, I'm not married, I want children. I want to put this off until I'm 40. Is that what I should do? And there's decisional conflict for it. What really struck me was, for me personally, I felt like you had to make decisions on a bunch of really bad options. And as I mentioned, urgency. I don't, can you read it there? Oh yeah, it's okay. I think for me, I was a ticking time bomb. I had to have everything done so that I didn't have to worry. And then the last one, and probably, you know, just as important as the rest of them, the implications for health and well-being, particularly in terms of the side effects from the risk-reducing options. A lot of women expressed that, you know, they knew why they were having their risk-reducing surgery, they were having their reconstructive options, but they felt that their long-term side effects from the reconstruction options weren't explained to them fully. So for one patient, she had an LD reconstruction, but she wasn't made aware of the long-term implications in terms of how that might affect her arm and her strength. And psychological care came into this one. And I suppose when we start a woman on a pathway, we advise that they see our psycho-oncologists to help them to formalize in their mind, is this the right time for me to do this? What women felt that this might be a tick box exercise. And is it better to consider the psychological care afterwards to check in with the patient to make sure that they're actually doing okay? Peer support, not surprisingly, came up as a massive thing. And women felt that, you know, hearing the lived experience of somebody who's been through risk-reducing surgery was much better than sitting down and talking with a professional. I think often the lived experience is what teaches us more than what the professionals know. So my hope would be that between the peers and the professionals that we'll be able to give you good guidance. Hopefully we have some part in it. And I think, it was maybe Terri that mentioned this, the oophorectomy it is described like it's a walk in the park. It's an easy surgery to go through. You have come in, you have day surgery, but what are the consequences of that surgery? And for this patient, it was psychologically difficult surgery. The ramifications afterwards, for me as a person, were far more reaching. So essentially, what our focus groups highlighted to us from the women was that there were several unmet needs related to the provision of information. And what we hope to do with this decision aid, it won't just be available to the women in St. James's Hospital, it is online available to everybody, is to address these unmet needs. The last phase of the content specification was the Delphi study. We had all the information we needed to include within, or we felt needed to be included within the study or in the decision aid. Now we needed to reach agreement on what would actually make it into the decision aid and how that would be presented. And usually that takes 3 rounds, but thankfully it only took 2 rounds, and all we needed was 80% to gain consensus. So what I'm going to do now is just show you very briefly. I'm going to fly through this. I'm conscious of your time short, so is what the decision aid looked like. So you can access it on your desktop, but also on your mobile phone. And it will divide BRCA 1 and 2 separately because they, as everybody's alluded to, they have very different implications. The very first page is a lovely video of Yvonne telling you what the slide is all about. What I will say, this is not prescriptive. We are not telling you what to do. What we're just trying to do is provide you with all the options, rather than handing you a booklet. And you're with the decision aid, the whole point is that you can work through these options and see how they apply to you currently and what's of value to you. And so Yvonne explains all of that to you. Then we move on to the cancer risks, and as I said, we separated into BRCA 1 and BRCA 2. And I suppose what really became apparent in the Delphi phase was that how things were presented in terms of numerical versus visual. And a lot of people find the visual, to look at that's obviously a lifetime risk. But we also have a graph for each BRCA in terms of the risk associated with their specific age. And for a lot of women, that's quite eye-opening. I had a session yesterday with new BRCA ladies. And they just had this idea in their head that right now their risk was 69%. And when I showed, because most of them were under 30, they were actually quite surprised to realize that the risk currently is quite low. And that was very reassuring because it allowed them to understand they actually had time to make decisions. Then we move on to what are your options, and you can just click into each of these individual screens. There's not lots of scrolling. You've got screening, or what we say surveillance. So that's with your mammogram, your MRI. It shows you pictures of how it's done. It explains the pros and cons of each one. The risk reducing surgery in terms of breast, and we do warn that there are photographs within the decision aids, so just so that, and you can click in and out of them, you don't have to look at them. And then we do include chemo prevention, because as BRCA group, you need to be aware that that is an option for you, and that is a good option for some women. And in terms of the ovaries, we've only included the ovarian surgery. So we haven't talked about transvaginal ultrasound or CA125 because they're not currently supported. As the evidence changes in the future, the website will be updated to reflect that. So the website will always reflect best evidence practice. And then that's just a little bit more. That's Miss Connie, so she's one of the breast surgeons at St. James, so she gives a little bit of an overview in terms of the mastectomies aspect of reproducing surgery. The website will allow you to compare your options. So you can compare surveillance to risk-reducing surgery to chemo prevention. So it goes through the pros and cons. And so everything that you need to know is in one place. And finally, what makes a decision aid is not just the information that's within it. It's clarifying your values, what is important to you in your current time of life. And there's lots of boxes within this that help you. So are you 28? Are you hoping to have a family? Do you want to breastfeed? All of these sort of things are included in the decision aid. And then finally is your readiness to make a decision. So you can go back to this and to the decision aid a million times before you actually make a decision, but everything that you need to know is in this. The last, within the decision aid, there are loads of videos because we're trying to make it as interactive as possible. So not just reading everything. We have information relating to HRT, to the oral contraceptive pill, how HRT is safe to use in an unaffected person who's had an oophorectomy, particularly when you've had it at a younger age because of its benefits in helping to reduce your cardiac, your bone, your cognitive issues associated with menopause, and to make you feel like you felt before you had the oophorectomy out. You can, as users, you can select what you want to look at. You don't have to look at things that you don't need to. And then we do link, because one of the things was where do you get the information from. So we will have links both national and international to resources that are applicable to you guys. And then there's a section on frequently asked questions. This is where we're at. So we finally nearly finished the prototype, which has taken us a long time because unfortunately we started this project beginning of COVID and everything went mental. So we're going to initially test it ourselves, and then we'll be looking at usability testing with the patients and the healthcare professionals. And at each phase of usability, the information we get back from those who test it, we will change how we present this website to you. So I suppose in summary, this decision aid was developed by nurses who wanted to respond to the unmet needs of the women who attended our service, but also for those who attend services in other hospitals. We wanted to be able to assist our ladies in making decisions about their risk management strategies, decisions that were valuable to them, and to facilitate more engaged, informed, women-centered patient care decision-making. As I said, the success of the project really was down to the fact that we involved the women that this decision aid was aimed at all levels of the project development. So in the governance, in the content specification, and soon to be in the testing of the website. Thanks very much.
I should be sacked because you were like the third child there. I gave you the worst introduction. I didn't give you a glass of water. Terri. So, and as well as that, as well as Carl, also we've got Yvonne Hanhauser, and we've got Dr. McGarrigle. So that's some of the team, and both Yvonne and, as I said, Carl are advanced nurse practitioners in breast unit in St. James's. And that's not an easy masters to get. So well done. And of course, Sarah, you're working as well with Trinity, aren't you, in research? So yeah, so thank you so much. And I think a bit what Carl says there, that fits very much in with our theme for today, BRCA in the eye of the beholder, because it is very unique to each individual. And I think the BRCA decision will help a person to be spoken to their needs. So thank you so much. Thank you to all our speakers this morning. And I think time permitting, we have time for some questions. I don't know, would the speakers want to come up? Would you want to do that? You might need to get another chair in here, I think, maybe. Have another chair. If you're asking the question, you might wait until I come with the mic. Yeah, Yvonne, enough chairs up here, Yvonne. Bring another one over. Here we go, one more. Okay, go.
Who's brave enough to ask the first question? So I have a question for it's Eoin, was it? Yeah. Hi. In the next few weeks, I'm about to tell my 4 daughters that I have BRCA2 mutation, and my eldest daughter is 19. So I'm wondering, I did it privately. I want to know, I'm trying to figure out which route to send her down. Quite an anxious individual. I don't want to wait 2 years for a test. So I'm wondering, what is your current waiting time?
Yeah, that's a good question. That always comes up. First thing I'd say, I suppose, to your daughters is that, like, at 19, they have lots of time to try and process the information first before they make a decision about doing it. Okay. The second thing I say is that some 19-year-olds will want to come and have a conversation with a professional like myself, and maybe choose not to have a test at that time, and that's fine as well. Okay, so if she wants to come and have a conversation and get the information and maybe ask the questions that she's maybe not comfortable asking you, or just talk about how she's feeling about it before she makes a decision, that's okay as well. Okay, so just because she's getting a referral to be seen does not mean that she's automatically, she has to have the test. That pressure isn't there. Okay, so particularly with younger women, I suppose in my own head, kind of women between maybe 18 to 25, I would always be kind of slowing things down a little bit, saying, exploring what they really know, how they understand things, how they're going to use the information straight away, because generally we won't start screening until the age of 30. And so then if someone tests at 19 or 20, they're left with this gap of maybe 10 years where they don't have any follow-up or support. And that can be really tricky. And I always reflect on patients myself that look, I went back when I was 19, I wasn't as sensible as I am now. And so, you know, there's lots of different things going on, like working in college, all these different things. So I would encourage you to obviously talk to them about it, and obviously before others, they're probably at different ages. Try and keep it age appropriate to each, you know. But once one knows that they're going to know about it, and that openness is really important. So they grow up knowing there's something there, they know it's something they will have to discuss, but there's no pressure yet. Okay. In regards to timings, like waiting lists fluctuate a bit. In Crumlin at the moment, we're sitting at roughly around 12-month waiting list to be seen for both diagnostic or predictive testing. And I know that's not ideal, but I suppose for your daughters, I suppose they have time to first process the information you've given them. And then at the time that they are seen, if they want to be seen, we can discuss things with them. But nothing will change in regards to their screening or risk reducing surgery or anything like that. That's all down the road if it's even there, you know.
So even an appointment for a chat where you're not looking for testing for strongness. So I don't think my 19-year-old, knowing her personality, will be able to wake up.
Yeah, and look, that is really frustrating. I think.
I'm sorry, I didn't want to send her, I did it privately, and I don't feel the supports, there's no system in place there, and that going to the different experts and whatever. I want her to go into a unit where there's supports.
Yeah, I think that's really important. I worked in the private myself for a couple of years before moving over to Crumlin, and I think, look, depending on what genetic cancer they end up speaking to, it is a very individual thing as well. You know, people have different personalities and do things differently. But my instinct would be she should probably be referred into Crumlin or St. James's, and then they'll be part of the system then. Okay. And again, just because we test somewhere else doesn't matter. And again, I think there is a common thread now where people tend to be maybe even ordering tests themselves from kind of American companies and things like that. And again, you don't get the support either before or after, and then you're left in a bit of limbo with that. So look, I think that's where the Marie Keating can actually step in a bit. They have, you know, peer-to-peer support workers. Some of them are actually quite young when they were tested themselves. So in that stopgap, that could be a really good place for the go, just to kind of turn to if they have questions or want a bit of support in the meantime. But like, a bit of waiting time isn't the worst thing either, because she actually gets time to process it and work it out. And if it is something that you think she is really struggling with, either repeating or even maybe, you know, psychological counselling or something like that in the interim, just to, because again, I presume she's probably been through a lot with what's going on in the family maybe already, you know.
In fact, they have no idea, because it's all generation ahead. They were before they were born.
Okay. So again, that can be quite a shock for them, because that's not even like they had something in the back of their head, oh, well, look, mom had this or auntie had this. Like, you know, we kind of knew there was something there. So that's going to be a real softly type thing. And I think like the Marie Keating Foundation's website is really good just for good solid information, but that's not going to scare the pants off here. But I think yeah, it's a tricky one, that gap. But actually, I kind of do think that having a little bit of time to process things isn't the worst thing.
Okay. All right, thank you.
Yeah. Could I come in just on the end of, sorry, just a comment, sorry, before the next question. It was just, Eoin mentioned mainstreaming a lot, you know, around people who weren't genetic counselors being involved in genetic testing. And a lot of the, we had quite in-depth discussions around whether mainstreaming was appropriate for somebody who doesn't have a cancer diagnosis, whether at that young age or an older age. And there was a very strong feeling that it's such a different thing, you know, when you don't have an experience of cancer. You know, mainstreaming is internationally really something that's used for people who already have an experience of cancer, that you're already in a system and have, you know, a team around you looking after your cancer diagnosis. So it'll make changes there in terms of getting people tested faster. But obviously the part of the point then is that it'll free up genetic counsellors' time. So there'll be a kind of a swing towards genetic counsellors having more time to see the people who aren't already affected with cancer, or obviously see people who are affected with cancer and then get the, you know, you still should see a genetic counselor afterwards and have all of those supports as well. But just so, mainstreaming isn't seen as a solution to everything, we really need our genetic counselors, we need more of them, but we also need to free up their time so they can see people in a more timely way, so, sorry, just, yeah.
Sorry, hi, I am BRCA2 positive, 3 years now. I'm a tick box person. I didn't have cancer when I got my sister, but she did. So my attitude is I went down the same route as that lady. I did a private, now I did go to Cromer for my testing. But after I had that, I had the oophorectomy, the mastectomy through the DX surgery, But I'm in limbo now. I don't know where to go, what to do after that. I don't know, because I did the private route. I went to the DMHL, but I haven't had any contact after that. So I don't know what to do next.
I suppose what we would do with the ladies who attend our services, they have misproducing surgery. You no longer require surveillance, and we tend to follow them up for maybe 18 months after the surgery. So we do teach them how to, it's still very important that you examine their breast. You reduce your risk by 90 to 95%. So we teach our ladies what to look out for. And we have an open door policy, so if they find something, then they can come back and see us at any time without a referral from their GP. But I suppose you're in limbo in the sense that thankfully you've reduced as much of your risk as you can possibly reduce. And so it's just being vigilant. So performing your monthly breast exam. And that's, I suppose, when you come to a service like ours, we're the first nurse-led service in the country. And we've got no feedback, thankfully, but we get that education and backup, so then you know when you're finished with risk reducing options.
So I wasn't told any of that.
Yeah.
Nothing.
Yeah, unfortunately, I think that's the missing link, isn't it? That you didn't get that knowledge that once you go through those steps, there isn't the need for sedate, so you are feeling a bit up. But as Carol said, that's kind of what we go through with our women, is that once you've gone through that risk reduction, you've got access to us all the time, but there's only a period of time that we actually do continue to follow you with the education that you need to keep an eye on yourself. So yeah, so it's just that access is important, and a lot of women like to know that they don't feel in limbo, that if they do need us, there is that availability.
Yeah, I think that's what they say. I think you can go down to the private route. They should be giving you the information of where you can get information after you finish your service. Yeah. Nice.
Anybody else like to ask a question?
Yvonne. I kind of have two questions, I suppose. One, in terms of the testing, why, I suppose, would oncologists be recommending that you go to a website to organise your own test rather than go through a...
I suppose what they're doing is they're not recommending, they're just giving you that option. So we would always recommend that you go through genetic counselors, you go through a cancer genetic service. But as healthcare professionals, we need to provide you with the information that's out there. So for some women, they don't want to wait. And what we've done in James is that there are women who go through colour, but we've organised it so if they test positive, that we can link them with our genetic counsellors in our services. So if we don't get the counselling beforehand, we make sure you get it afterwards. So that we're recommending it, I'm just giving you that information.
Okay, so in my situation, I was having mammograms because my sister died in her 40s, and then I picked up breast cancer, and I was given the Colour website with all of her, and it took me many months to find it myself.
I suppose we can only speak for what we do, but if you were in our service, we would refer you to cancer genetics.
Yeah, and then my second question, and I it's really around metastatic breast cancer. There's a huge campaign of breast cancer Ireland at the moment, vaccinations and everything else. But I think, everybody kind of, you're trying to keep things rational, but like in my experience, when you go with symptoms, you're not kind of referred for testing for anything. You go to your GP or to get an appointment with an oncologist, it's not very easy. Where do you go, if you feel something's not right?
When you've already been diagnosed with cancer?
Yeah.
Well, I would hope your GP. Ignore, I suppose, when you had a breast cancer diagnosis, you're generally following Trinity for 5 years.
Mm-hmm.
then an annual mammogram. Because you've been discharged from clinical follow-up within the secondary care setting and the primary care GP is the person who's recommended that you go to.
They don't link you
Back in, yeah.
yeah.
And they should just refer you back to your previous treating doctor. And we see that all the time. We try actually for us into our service. And so your GP can just link you back in with your treating hospital. That's what should.
Thank you.
And I would add to that, unfortunately, that I think sometimes you have to become your own advocate, you know. We had a seminar yesterday as well for colorectal cancer. A lot of the ladies were saying that they really have had to advocate strongly for themselves when they felt something was wrong. So we shouldn't have to do that, but unfortunately we do.
Can I just jump back into the first point about this kind of consumer testing or direct testing? Look, I think part of it is probably because genetic services traditionally have had long waiting times, and there's doctors now who presume that, oh God, you'll be waiting a year or whatever it is to get your results. We can actually accept like urgent referrals. If it's something that will change a woman's treatment, you can be urgently referred to us by your oncologist or your surgeon. We will test clinically and we'll get you the result back, and you will get the support around that. Now again, I think this will all change once mainstream becomes more and more the norm, that these doctors can actually be ordering the tests themselves. But you should be referred to genetics if something is found on one of these tests. And again, we don't have control over how people do like behave in these sentences, but like you should, and your family should be back in for like a follow-up appointment. It's not ideal. I think it is the way it's going to go because it's quick and it's easier, and people get the answers they need to get, or they get the result that you don't have anything to worry about. And that's what people kind of go into with. But I suppose my whole profession is based around preparing people for having these tests and guiding them through the process and supporting them afterwards. And so look, again, there aren't enough of us to get that, but just a warning across the board that just to be wary of that. Okay, there are benefits of doing it because it might change your treatment, but you can sometimes be left in a limbo then with no support. And if that's the case, get a referral to genetics and we'll pick pieces on the far side if we can.
Can I just ask then as well, colour is, I believe, a saliva test, whereas the other one where you get cancer is a blood test.
Yeah, so it's all the same. So basically you're getting DNA from either type of sample. So again, we've no questions over the quality of the testing done through colour, but it's just sometimes the casing bit is left behind, and then you're left in a similar position where you're kind of left kind of not knowing where to turn. And that's why going through one of the services, either in St. James's or in Dublin, we will do onward referrals. We will link you in with screening or surgeons, whoever it is who needs to take that next steps. And then also we'll be able to look after the family members for when they're getting insights.
Thanks.
We'll take one final question from Leica. And then there's one final question.
Is it open? Yeah. Hello. I was diagnosed with cancer 5 years ago at this stage, so maybe my experience is a bit dated. I had bilateral triple negative breast cancer at 47 and a strong family as well. And yet I was told that I was too old to have BRCA. And I was also told that I would have surgery and then it would take a year for me to get the genetic testing done. And I didn't accept that, and I decided to go privately. And within a month, I had my diagnosis, and I'm BRCA positive. I don't understand. The clinic where I went to was a public hospital. They didn't know that you have an option, and to me, it was life-changing because of treatment options, although I had already had my first surgeries, and unfortunately, they were lumpectomies, and then, so I had to face, a second time I had to go to mastectomy 2 years later. And I'm wondering, for me, it was a hurdle, and to be told that I have to wait a year to get a genetic counseling before I had the diagnosis, to me, it had no sense at all. Because once you have cancer, you don't care about the counseling. You want to know what your options are. So I'm just wondering if this has changed, because for me it was a further hurdle hurdle to find a private geneticist and have a test done and find it. And even in the hospital where I went, they didn't know it was possible. So I'm just wondering if this has changed because it was really hard for me.
I think there's probably an education piece that traditionally has been missing there, where it's very hit and miss depending on who you see and who your consultants are, or who your breast team are, that what they know about, you know, genetics and referring and what your risks are. That's one issue. Again, NCCP were working on that education piece, and again, that idea of having to wait a year to have a test. Because we're trying to get the message out there that if there's urgency, that it will change your treatment. We will get you in, we will get you treated. But again, that message isn't out there, and some of the rest of maybe don't know about that. But again, diagnostic mainstreaming should change that. Women in your position in the next few years should be offered a diagnostic test through their breast team with specialist counselling from surgeons or AMPs or people locally, and then you could be referred into genetics afterwards if something is found.
I suppose what has dramatically changed is that most of the breast centres now have an advanced nurse practitioner who's family risk orientated. So thankfully, yes is the answer. It's changed.
I would say I hope it has improved since 5 years. But just to clarify from what we're seeing now is that when we were diagnosed with breast cancer, generally, would you agree, women seem to go through the testing pathway more likely? It's predictive testing. I'm finding there's an accessibility problem there. Where you hear these 12 months waits, I would say longer.
In James, we have
18
24
plus, yeah. So it's really unacceptable for that group of women. Because some women who's diagnosed, I would say there definitely is a timing issue because you want it quickly, but like Eoin said in his talk, it's a sensitive time too, and there's a lot of things you have to deal with at that time. And just to kind of say as well, there is a move towards women getting their, say, what we call neoadjuvant treatment, when they get their systemic treatment first, and I'm finding that's helpful in that women probably get tested in that period. So we're finding that is working well. Just to reassure you, I think it has improved is the answer. And I think around the sensitivity and the timing, when it's not too quick and too rapid, there is an element of that. And I think the women that have the systemic treatment first pre-surgery is kind of helpful in that they have a little bit more time to get the test done, think about it more, and it helps in that setting.
We've got one final question here from Linda. Hi, I was being treated for triple-negative breast cancer last year. My oncologist directed to other tests, and obviously it was brutal because there's no lack of support. I never knew anything about cancer. Didn't even know it was negative, genetic, anything. So people were okay. But she was away when my girlfriend was vaccinated and really never did. And she didn't recommend anyone going to where she could go meet that option. The reason she did it was to see. But my question is, I have two adult children. To get my treatment out of the way and tell them. Yesterday, I was checked as a proportion. Something very said to me, if it was the case that was my daughter who came in with a positive test, she should reconsider explanation and be better. So again, this is very always. So any thoughts on that process? And I think Eoin briefly mentioned that we can do testing on the areas and stuff to see whether we can help the patients. Again, it's a completely new learning.
That's okay. We can talk a bit briefly about that. I suppose it's up to you when you feel comfortable telling your children. In a sense, if you've got daughters and they're under the age of 25, it's unlikely it's going to change anything in regards to screening, even if they're under 30. But at the same time,
having the family is the question.
Yeah.
For girls now, we tend to have career.
Yeah.
We're all having babies.
Yeah. So.
Probably be.
Yeah, and that's I think where the genetic instincts come in, whereas that's a large portion of the conversation we'll be having with maybe someone who's 25 or 30, who is, you know, getting that stage of life of thinking of those things. A lot of it will be about we look at risks. So there are different options out there. Most women or even men who are found to have a fault on BRCA1 or BRCA2, they'll decide to have children the normal way, okay? And you know that their children can be tested once they're over the age of 18 to see whether they have the fault gene or not. That's the road that most people go down. And it is tricky. Some people feel that they don't want to kind of that burden of responsibilities maybe a bit too much, and they don't want to have a child who is affected by who inherits a faulty copy of the gene. And so there are kind of IVF type options. The main one we call pre-implantation genetic diagnosis, or PGD for short. And what they do there is, so IVF is generally when people struggle to conceive naturally. And what you do is you take the egg from the female, the sperm from the male, and you create embryos in the lab. Now, if there's a genetic condition in the family, what we can do is, before the embryos are implanted into the womb, we can test to see that they have the normal copy of the BRCA gene or the faulty copy of the BRCA gene. And then you would only select and use the embryos that have the normal copy of the gene to implant into the womb and try and cause effects. So in that way, if that IVF process is successful, you would know that that child would not inherit the faulty copy of the gene, and therefore you wouldn't have to worry about that going forward. Now, the only major issue with that at the moment is that it's not currently funded through the HSE. There is talk and work going on about that, but it's at very early stages. So that kind of PGD will cost roughly around €10,000. There are 2 specialist centres in Ireland that do it. There's a PGD centre in Beacon Care in Sandyford, and also Waterstones in Cork. So again, that's something that we would talk to patients about. It is something that they actually had to have a meeting with a genetic counsellor with before they'll be seen by and like that. But that's something that we can go into depth with your children. And the idea of having eggs frozen, I don't think there's much sense to that. And again, what we can do now that we probably haven't been able to do before is we have certain like special software we can use that can actually give a woman, well, what is your risk of ovarian cancer in the next 5 years, the next 10 years? And so actually, it might be that the risk of developing ovarian cancer before the age of 45, if it's BRCA2, might be actually surprisingly low. So women might use that information to choose and say, well, I'm going to wait until I'm that age to have that done. Or it's about weighing up the risk of getting ovarian cancer with what you want to do, and if that's to start a family later, you know, so there's a balance there. No one's going to say you have to have it at 35, you have to have it at 40. There's a discussion around that. And again, that depends who you see as well. If you see one of the, the advanced nurse practitioners, they're going to have that sense of it. Sometimes you might need a quite direct gynecologist who just says, no, the nurse says 35, you have to have it done. That's not the way it should be done. It should be a kind of a collaborative approach, a shared decision-making approach. But hopefully that answers one.
Can I just ask you something? You said that you did colour, but have you been referred to somebody?
No, well, I've had most of my treatment now. No, when I was being treated for the things that we didn't know there was a history in my family, so there was odds of that. The oncologist said that treatment is very mutual, we went to very long. And I think it was the speed that they needed the results of. So I thought, what to do next? Well, I said, I'm only married to anyone I do. I do it. I mean, they do give you a counsellor as this part of the big and it's on, but I mean, talking to the lady, it's like research and everything, treatment, they have to say it's completely different from here. So, it was quite an interesting few days for that way. So, I mean, what we can Dr. Google to get the rest of the information. So, no, I was never referred on.
I was gonna say, I think again, that's the issue. You need that follow up when you get the results, because we have quite a lot of women that are unaffected women that are waiting a long time for predictive. It's there now. It's not ideal, but it's rapid and it's affordable, because this was really not very affordable a few years ago either, whereas this is. So it's going to become much more commonplace.
I mean, it's amazing.
Yeah.
$300
Yes.
or euros,
Yeah, absolutely, but it doesn't just do BRCA, there's a whole panel of genes. And what do you do with that when you get that information back is a huge resource implication for genetics actually. Because yeah, you can get it online and you can go do it, but what we're really saying is you need to have some sort of, and the GPs may well be saying, right, well, I need to refer, well, they should be referring that to genetics, or but it's a resource and it's accessible. That's the thing.
Linda, isn't it?
Yeah.
Linda, I think seek a referral in to see us in common, either by a GP or your oncologist, just because you need a discussion about this yourself. You know what I mean? You need the space to kind of debrief and chat about all of this, get your own head around it. We can take your family history, we can give you information for your family. You know, if you've got brothers or sisters, aunties, uncles, cousins, they, especially if they're older, like they need to know about it. And that's the bit that gets left behind, is that actually, how am I supposed to tell my relatives about this? What am I supposed to do with it? And again, it's a really hard place because you're in the middle of your treatment, and then all of a sudden you've got all these other things to worry about, all these other things to try and organize and do. And that's the last thing you need, you know? So just for yourself, get a referral in, and you will be seen and you can talk about it. But I suppose, look, it's a theme that's coming up. I think yeah, the testing can be really important to help the treatment, but you're then left to manage the results afterwards. That's what we're hopefully going to sort out in the future, is that the mainstreaming will be more accessible. You won't be expected to have to do that yourself, and there should be a team to pick you up afterwards and help you and the wider family if something is found.
Okay, so in the interest of time, we're going to close off the Q&A. Thank you so much for your contribution, and to everybody for listening to the questions and answers. And thanks so much to the expert panel as well.
Yeah, second calendar. Thank you so much to our expert panel this morning. Fantastic, and thank you for staying on longer, because we were, you know, we kind of ran over, but I think it was necessary to get Q&A. I know I did mention when we came in that we were going to give Dr. Christina Cal a few minutes to mention about her research. I'm not sure if Christina popped out or Elaine. I think so. Is that okay, Christina? And it's important though what you have to say, so I think yeah, done. And can I say 2 topics came up there in the questions: communication and also about, you know, PGT. These are topics that are going to be discussed this afternoon. We have an expert on communications coming in from the States, so she will talk about the differences. And we have our 2 wonderful ladies, Tara and Lisa, will be up there chatting about communicating with children and teenagers and young kids. And then we also have Dr. Karen Padu talking about the future and PGT, etc. So lunch again is upstairs, first to the right. You'll see a sign in the Bay and Sorrel restaurant. You'll see a sign for Marie Keating. Could we be back here? What time are we now, Helen?
It's 10 to 1.
Is it possible to be back for 1:30? Is that all right? I think being Friday, we'll try and not delay things this afternoon, and we'll get finished on time. So thanks so much. Thanks so much, Eoin. Thanks, Trina. Thanks, Carly, Yvonne, and Sarah. Thank you, everybody.